Hello, this is Hadi Lichaa with DocWire News. I have the pleasure of having Dr. Vladimir Lakhter with me. He is an expert on chronic thromboembolic pulmonary hypertension interventions. And we're going to be having a talk about this field of cardiovascular medicine that's growing. Welcome, Dr. Lakhter.
Thank you so much, Dr. Lichaa. Thank you for having me. It's a true pleasure to be here.
I
Thank you so
am
much for this
thrilled
opportunity.
to talk about this with you. And first of all, tell us a little bit about yourself and where do you practice now and how did you get introduced into the thromboembolic world?
Sure, thank you. Yeah, so my name is Vlad Lakhter. I'm an interventional cardiologist and endovascular specialist at Temple University Hospital in Philadelphia, where I've done most of my training. Early on in my career as a trainee, was lucky enough to meet my mentor, Dr. Riaz Bashir, who's been doing a lot of venous work for many years, prior to me even joining the center, and has actually started doing balloon pulmonary angioplasties several years before I started as a fellow in cardiology at Temple. And so because he was my mentor and we were doing a lot of research together and I had an interest in vascular medicine, I ultimately got involved in doing cases, balloon pulmonary angioplasties for patients with chronic thromboembolic disease fairly early on as a general fellow, the interventional fellow, and then continued doing that in my endovascular year at Mass General with Ken Rosenfield. And then came back to Temple and have been doing um, interventional cardiology, vascular medicine, but also quite a bit of chronic thromboembolic work, and mostly balloon pulmonary angioplasty side and pulmonary angiography for patients with CTEPH.
Excellent. Thank you. So let's start with the definition of CTEPH. What is CTEPH defined as and what does it stand for?
So I think the way I think of CTEPH is a patient who sustained a venous thromboembolic event, pulmonary embolism, that of an acute nature, and was then treated with proper anticoagulation for at least 3 months, but continued to have symptoms after treatment. Usually those symptoms are dyspnea, poor exercise tolerance. A lot of these patients will have some degree of right ventricular dysfunction. And by definition, they have to have pulmonary hypertension. And also you have to establish the fact that they have chronic thromboembolism, and the best gold standard for establishing that diagnosis is a perfusion defect that's unmatched on a VQ scan. So putting it all together, somebody who had an acute PE and after 3 months of anticoagulation has persistent mismatch on a VQ scan and has evidence of pulmonary hypertension and echocardiography and is symptomatic. So
So
those are the
every
basis of.
single patient gets an echocardiogram, a CT scan of the chest with IV contrast. If they can, from a renal perspective, VQ scan, and sometimes a CPET, a cardiopulmonary exercise test. Is that part of the mandatory workup?
So I think a lot of the patients that come to our center who have already been evaluated by their local either cardiologist or pulmonary physician, a lot of those patients would have had CT angiograms and VQ scans, sometimes even right heart catheterizations. I think in thinking about whether a patient has CTEPH, generally I get an echocardiogram and the VQ scan, and then ultimately if there is if there are findings of CTEPH on those two studies, then I would consider getting a CT angiogram to really define, the extent of it and prove that there is a webbing or occlusion of pulmonary arteries, and figure out how proximal the disease is, and to determine whether the patient has surgical disease and they're a surgical candidate. So I think, but definitely VQ scan and an echocardiogram in everybody who had a prior history of pulmonary embolism, and the timing of that is variable, and you'll see that being done after 3 months after acute event, and some centers will do it after 6 months, so somewhere between 3 and 6 months, especially in patients that are persistently symptomatic of any kind, either have poor functional capacity, decreased exercise tolerance, or very dyspneic. Persistently after 3 months, I would get at least an echocardiogram and a VQ scan, probably follow up with a CT scan down the line.
And the definition of pulmonary hypertension, could you update the audience on that?
So actually, the way it always used to be up to recently is that basically pulmonary hypertension is any pulmonary artery mean pulmonary artery pressure over 25 millimeters of mercury. But more recently, I think the guidelines, especially the pulmonary hypertension specific guidelines, suggest that maybe we should be thinking about pulmonary hypertension in anybody who has a mean pulmonary artery pressure over 20 millimeters of mercury. So that's still that's so anywhere between 20 and 25, but definitely over 25 is pulmonary hypertension.
So that's, I mean, a substantial difference, between 20 and 25, you're talking about at least, 20% more patients. There are a lot of patients that kind of qualify for that. So even the soft, pressure of 23, mean pressure of 23 is still abnormal. Now, I had the pleasure and the honor to visit your center, and I obviously saw how much of a well-oiled machine you guys have at Temple. Talk to us about the pulmonary angiography specifically, and I know you're a world expert on that. You've given multiple talks on it. So obviously, in summary, obviously we can go through the specifics, the technical specifics, but what is, in your opinion, pulmonary angiogram has to be done at a center of excellence. Is that correct? Or an experienced hands?
Yeah, I think so. We definitely have referrals that come through to our center, and sometimes patients will already have had a pulmonary angiogram. And definitely, there are times that the pulmonary angiography is excellent. There's a lot of variability I find between the techniques that are employed for pulmonary angiography, and depending on which what the patient's ultimate outcome is going to be, sometimes we have to repeat those pulmonary angiograms. For example, our surgeon. He's a world expert surgeon, Dr. Toyota. He really likes to have a pulmonary angiography done in two views, AP and lateral. And I think that really helps him define the surgical planes and plan out the pulmonary thromboendarterectomies that he will ultimately have to perform. And so, but depending on the operator and depending on the center, you may or may not get the same angulation. And so I find that pulmonary angiography is really tends to be center specific. We tend to repeat quite a bit of our own pulmonary angiograms, specifically for planning of surgeries or planning of balloon pulmonary angioplasties, so that we can make a plan based on that. In terms of, I think pulmonary angiography is done as a later on test. It's not something that patients will get upfront. And some patients don't really need a pulmonary angiogram if there's very clear evidence of proximal chronic thromboembolic disease on CT angiography, and the surgeon is happy with the fact that if the surgeon is happy with the quality of a CT angiogram and they can really plan out their surgery based on the CT angiogram, then we're not called upon to do the pulmonary angiogram. But a lot of times I think there is a question of, okay, we're seeing something on the CT scan. We're not quite sure if that's a web or if that's an artifact related to flow of contrast or timing. And in those cases, we will perform pulmonary angiogram. So I think in the majority of cases, we do it. I think that really helps us and the surgeon decide if the patient has surgical disease. If so, they should go for surgery. And if they don't have surgical disease or if they're not a good surgical candidate, then we can use the pulmonary angiography to plan out balloon pulmonary angioplasty if that's the way the treatment team decides the patient should be treated with.
Excellent. So now we have a pulmonary angiogram, which is a detailed study, very well performed. Which kind of patients are the patients that you think are good candidates for balloon pulmonary angioplasty or BPA?
Yeah, that's a great question. I think one thing to point out as probably one of the most important things is that most patients with chronic thromboembolic pulmonary hypertension should undergo surgery if they're surgical candidates. I think that's the main thing. When we're getting these patients for an evaluation, we're really trying to decide, is this patient a surgical candidate? Because surgical pulmonary thromborectomy is really the gold standard for treatment of patients with CTEPH, and an expert surgeon can really cure the patient of chronic thromboembolic pulmonary hypertension. And we've had really incredible results with patients who have undergone surgery at our center. Now, there's going to be a couple of groups of patients that will ultimately either not get surgery because they're a poor surgical candidate due to comorbidities, or they're a poor surgical candidate due to the fact that the disease is very distal and the surgeon may not feel that they can get really to the subsegmental level, the type 4 disease, or some patients really don't want surgery, even if they are a surgical candidate. So that's kind of one group. And another group are those patients that have undergone pulmonary thromborectomy, but have residual pulmonary hypertension after surgery. And that percentage of patients could be anywhere from 20 to 30%. So I would say that the majority of patients that we do BPA on are those who are non-surgical candidates and have not undergone surgery in the past. And I would say that about maybe 10 to 20% of all patients that we do balloon pulmonary angioplasties on are those patients that have residual CTEPH after surgery. And really, in thinking of how is that possible, the surgeon may be able to get the very proximal disease. But again, if there's a very diffuse distal disease and some of that disease is not able to be removed surgically, even though you may have a substantial hemodynamic improvement, you may still have some residual pH from those distal lesions, and that's something that we can approach with BPA.
Excellent. And you mentioned, stage 4 disease or level 4 disease. Could you elaborate on this classification? What's 1, 2, 3, and 4?
Yeah, sure, of course. So level 1 disease is main pulmonary artery disease. So if you have a main pulmonary artery occlusion, right main pulmonary artery or left main pulmonary artery, that's as proximal as it gets, effectively, except if the patient had a complete total pulmonary artery trunk occlusion, which is not really compatible with life. So the patients that have CTEPH, the most proximal disease is level 1 disease, occlusion of the main pulmonary artery. And as you move out distally from the main pulmonary artery, you get level 2, 3, and 4 disease. So level 2 disease would be occlusion of the interlobar artery or stenosis of the interlobar artery. So you don't necessarily have to have a complete occlusion, but you may have thrombus, the chronic clot that extends, and the clot starts at the level of the interlobar artery, and then most commonly involves then segmental and subsegmental branches. It's usually not just limited to the interlobar. Level 3 disease would be main pulmonary artery and interlobar pulmonary artery that's free of clot, but the disease starts at the segmental level. And level 4 is basically everything else, subsegmental disease, subsegmental disease.